honestly, as a floor nurse, and I mean, I feel like we didn't even really learn anything else, even in nursing school, about how to treat hyperkalemia, but Kayexelate. So I had a patient who had a potassium of 5.7.
That's pretty high.
And, you know, this patient was also not really alert, not really oriented, but able to swallow. So Kayexelate comes in like a liquid form.
Yoo-hoo! It looks like that Yoo-hoo chocolate milk.
Yeah.
Did you ever drink that as a kid? Doesn't taste like it.
Welcome to the Shift Report.
Episode 10.
The final episode of the year.
Yes, it's our season finale. So season 1, episode 10, we are here. And this is one that honestly I didn't really even think about until you brought it up. And I was like, oh man, this would be fantastic to talk about. Because majority of the things that you were talking about, I had no idea.
Well, I was seeing a lot on my floor too.
Yeah.
Like lately. So I was just like, this isn't always treated properly, or it's not recognized as well or early as it should be. So I thought it'd be great.
You guys are tuning in to The Realist Nurses on Instagram, The Realist RN, on YouTube, Spotify, Google Podcasts. You can find us, like, subscribe, hit the bell for notifications for all of our new stuff coming up next year with season 2.
Yeah, it was a short year.
I mean, I feel like we started and we ended. It went by fairly quickly.
Yeah, and then of course COVID.
Well, COVID is COVID, and I think it will be around for quite some time despite vaccinations and whatnot coming out.
Yeah, so hopefully we have a full season starting 2021. Can you believe it's 2021?
Wild.
We got like 25 days left. Not even. It's like 20 days left.
Seriously. But coming back to our topic, hyperkalemia.
What is that?
So hyperkalemia is basically a elevation in your serum potassium levels. A normal range of potassium is 3.5 to 5.0.
Yeah.
So anything above 5.0, your body is in a hyperkalemic state. And honestly, as a floor nurse, and I mean, I feel like we didn't even really learn anything else, even in nursing school, about how to treat hyperkalemia, but Kayexelate. So I had a patient who had a potassium of 5.7.
That's pretty high.
And, you know, this patient was also not really alert, not really oriented, but able to swallow. So Kayexelate comes in like a liquid form.
Yoo-hoo! It looks like that Yoo-hoo chocolate milk.
Yeah.
Did you ever drink that as a kid? Doesn't taste like it. Looks like it.
I mean, I don't know what it tastes like. I've never tasted it, but from what people have told me or what I've seen and reactions of patients, they're like, this stuff is terrible.
Yeah.
It's horrible. Why would you do this to me? I've pretty much heard it all.
The funny part is
it's so thick.
Yeah. The funny part is potassium liquid also tastes like crap.
I heard.
So when you're hypokalemic, potassium tastes like shit. Yeah. I've tried both actually as part of a dare.
Have?
Yeah, I have in the past. As well as some laxative, but it was part of a dare. That was many years ago. Young and stupid.
You have some guts.
Yeah.
I would not. No, thank you. Self-torture is not my thing.
Right.
So yeah, it's like a very thick consistency, and you really have to shake it up in order for these patients to drink it because it's like goo.
Yeah.
But so that's really so with this patient who's not really alert oriented, to try to get him to swallow such a weird consistency of fluid was such a challenge. And I was like, there has to be a different way. But honestly, I didn't even know. I didn't know that there were multiple ways to treat hyperkalemia aside from Kayexelate. until
Right.
you brought them up to me. And I'm like, wait a minute, what?
I've never done this.
Yeah.
Yeah.
So some of those ways are IV insulin and D50.
I use that one a lot.
I didn't even know.
Yeah.
Another one is nebulizer treatments.
That's not as common, but we do use it.
Okay. See, again,
No idea.
I wonder if RTs even know that.
I'm sure they do. At least in my facility, they do.
Sodium bicarb.
Yeah. That's usually used like as a buffer. So
Okay.
usually,
So what do you mean by buffer?
so it's mostly used in renal patients because, renal patients have all sorts of electrolyte imbalances. And depending on where they are in their care, you may not see it on the floor as much because your patients are stable relatively and can still get like hemodialysis and all that stuff. But when you start talking about ICU patients that you can't dialyze normally and there are all slower dialysis, or for whatever reason they haven't been dialyzed in 3 to 4 days because the state of their care is so, I don't know.
Right. It could be a number of things.
Be a good buffer. Sodium bicarb helps to like fix their acidotic issues. It helps bring the body back to some sort of normalcy. And it of course helps reduce the free-flowing level of potassium at times.
Interesting. Huh.
Yeah.
And another crazy thing that you mentioned is looking out for arrhythmias.
Well, yeah, of course.
I know that, we learned that potassium, it has a direct correlation with the heart. So anything low, anything
Right.
high can affect the heart. But, on a floor like mine where every patient is not necessarily on telemetry, it's like that's such a challenge.
Right.
At least that one, looking out for arrhythmias, because we can't really catch an arrhythmia if that patient's not specifically on tele. So
yeah, and I mean, here's the thing. So I also see it. Kayexelate is most commonly used. But what do you do when, because for Kayexelate to work, your patient has to defecate. They have to poop. So you give Kayexelate, and you're just like sitting there, just waiting for your patient to poop, and then they have these serial BMPs or serial labs to make sure that, the potassium is actually responding to your treatment. And then you're just like, well, my patient hasn't pooped. And you're sitting there and then potassium goes from 5.7 in your case to 6.3 to 6.5, 6.6, and your patient's not pooping.
right.
What the heck do you do? So Kayexelate's cool. Like, I get it when people use it.
Yeah.
But man, it can have some delayed like interventional value, like sometimes it just doesn't work because your patient doesn't poop right away at least. So in that time we give insulin and D50. So pretty much all these treatments work in the same way. They take potassium that's available in your blood and they shift them back into your cells. So then your free-flowing serum blood level doesn't have the potassium it did before the treatment. So insulin is actually the drug that works.
Like immediately.
Yeah, it's supposed to drop it, I think, like 0.5 to 1 milliequivalent or whatever per liter.
That's a lot.
Yeah, like a point, pretty much like a point, half a point to a point.
And almost immediately. So they don't have to go through that whole process of, all right, now I have to have a BM. Now I have to have a BM.
Yeah, so insulin is actually the reason why the potassium goes back into the cells. The D50 is given because what does insulin do?
Of course, it's going to drop your sugar.
It drops your blood sugar. So you give a D50 as a counteractive balance to giving the insulin. So we usually push IV insulin, so not sub-Q.
Right.
It's IV insulin. You push it, and then you immediately push D50 after that. Of course, you're going to recheck your potassium maybe an hour, 30, 40 minutes later, whatever. But you also want to make sure you continue to monitor your patient's sugar, especially if they're diabetic.
Yeah.
Or if they're like NPO or something. The other way is not even just IV insulin, but what do you do when it doesn't work either? Your patient's not pooping, you did IV insulin, it barely dropped, and your potassium is still 6. You can only push so much IV insulin.
That's true.
Right? You're not going to keep doing it. Like I've done 30 units, I think, over the course of 2 hours maybe. Maybe less, maybe more. Can't remember. It's been a while since I've pushed that much.
But even that 30 units IV, that's a lot of insulin.
Yeah.
And for it to still not work.
Right. And this is the ICU we're talking about.
Yeah.
Probably not going to happen on the floor. That's
Right.
probably a patient that needs to be monitored a little bit closely, especially if they're more symptomatic. But you can put them on a nebulizer, albuterol, a beta-adrenergic drug.
So how does that work? Like,
Same
what's
way.
the patho behind
Same exact way.
nebulizers?
Same exact way. It helps push potassium back into your cells.
Out of your actual serum.
Serum, like your free-flowing potassium decreases because your cells absorb more. But one thing you got to keep in mind, though, is all that stuff is going to come right back out eventually. So the key is it goes into the cells. Your serum or outside your cells, extracellular potassium drops. But eventually, over time, when those drugs are metabolized, your potassium is probably going to come right back out. So what are you doing in the meantime to solve the problem? What's the key issue? And I think that's what happens a lot, is that we temporarily fix the potassium,
Sure.
but we don't solve the baseline issue.
So why? The why behind
Yeah.
the issue.
Yeah, why is this patient's potassium so elevated? No one really not many people discuss that as often as they should, or question as to, okay, so we fixed it temporarily. We've got, 6 hours, 8 hours to figure it out. What's going on? That's when like those renal consults come in and you start talking to the kidney doctors and like, hey, I'm having severe electrolyte imbalances. I need to figure out what's going on.
Right.
Stuff like that.
So then what's the correlation? So we talked a little bit about the sodium bicarb as that buffer. So what's the correlation with the arrhythmias?
So the arrhythmias, pretty much your heart, it gets blood flow too. So whenever your electrolytes are imbalanced, it's not just potassium, it's all of them.
All of them.
Magnesium, calcium, potassium, chloride, phosphorus, all that stuff. When you have any one that is too high or too low, your heart isn't going to function as well as it should because it helps with the transfer of the electrical activity in your heart. Like there's a much more complicated pathophysiology that I think is in way too much depth for this. But when you have way too much free flowing potassium, your heart gets really excited. Starts going, oh my God, all this potassium, starts dancing around. That's when you start getting these weird PVCs and, your heart has these extra beats randomly for those people that don't know what a PVC is.
Yeah.
Or some sort of arrhythmia.
Are there any specific ones that we should be looking out for in direct correlation with potassium, or it can really be any arrhythmia?
I mean, I've seen all of them, depending on how bad the hyperkalemia is. I've seen a ton.
Okay.
The one I see most common are PVCs, though.
Okay.
At least with floor patients, is that you'll start seeing these random ventricular activity out of nowhere because you have your QRS, whatever.
Of course.
And then you'll see a little PVC right before it, So those are the kinds of things you have to cut and keep around or keep an eye out for. But more than that, it's recognition of the problem and knowing when you take an intervention, how long it's going to take. Because say you gave Kayexelate, right? You gave it, didn't work. And then you're like, okay, this is not working. I need to do something else. So then you try the insulin and the D50. That'll work most of the time, right? And then what if your patient poops then?
So now you probably have hypokalemia.
Yeah, depending on how
Possibly.
aggressively you treated it, yeah, you could. So you have to be careful. That's why I don't like Kayexelate. It has a delayed response, if a response at all.
Right.
So I don't like it because I don't know when to expect a result. I can expect a result with IV insulin fairly quickly, and it's easier to control at that point.
Especially in those ICU patients where, you can push it and you can monitor it
Right.
constantly.
So that's the biggest difference.
Okay.
And then what I don't see a lot is people giving the calcium gluconate when a potassium is so severely elevated that it's causing arrhythmias. You can give calcium to kind of tame the heart, to tame it and say, chill out, chill out here a little bit.
Okay.
Calcium goes in and it helps decrease the excitability of the heart in a hyperkalemic state.
Interesting. Okay.
It's a good drug to give. So next time your patient's hyperkalemic and it's like 6 and you're treating it, maybe ask the physician, like, hey, do you want to give some calcium gluconate or some calcium chloride or whatever? Let's give this patient some calcium while they're in this hyperkalemic state, just so that we don't get any crazy arrhythmias.
Yeah.
You know, it's like a buffer, balances it out. It's pretty much what it does. But,
interesting.
Yeah. And then, you got hypokalemia. And the reason we're not talking so much about hypokalemia is because what do you do when a patient's hypokalemic?
You give potassium, whether that's oral, PO, liquid, IV.
Yeah. And what do you usually give? What form?
So it depends. More recently, I had a patient who had a potassium of like 3.2. So not super low, but low. And she had 40 MEQ tablets ordered.
The
and then
horse
she had
pills.
40 MEQ, the horse pills. They're huge.
Yeah.
Most patients just want them split, in
I would
half.
too. And they're disgusting.
Yeah. They like dissolve super fast and they're like, wait, what?
Yeah.
And then, so she had 40 MEQ tablets and then she had 40 MEQ IV. And she was like, nope, I'm not going to take the IV. Have the physician put it back into pill form.
Why? Because it burns?
Because it burns.
Yeah.
And I never have patients complain about medications ever. It's always potassium. Potassium is that one medication that every patient everywhere always complains of, whether it's the horse pill, whether it's the liquid form,
Ugh.
or the IV.
I used to mix my liquid form with orange juice. Most patients said that tasted pretty good.
Okay.
So just OJ.
So I've offered to mix the oral liquid form with something and they're like, no, I'd rather just take it as a shot and get it over with. And they literally just chug it and call it a day.
Instant gratification.
Yeah.
Or dissatisfaction. But I've also noticed that if you piggyback some sort of fluid drip with your IV potassium, it helps. So not piggyback the IV on so the potassium can go, but, hook up some saline to your potassium line and on a different pump have it go at like the same rate as the potassium. They're compatible. So it helps dilute that potassium infusion and it helps, I guess, doesn't burn as much. But then you also have to keep in mind, like, is my patient fluid overloaded or do they have heart failure? Or
Right. There's a lot of other factors that factor
so just do that. You have to think about all of it, but that's one way. The pills, splitting them up. And then, of course, the liquid is, how do you like your poison? Do you want it as a shot or do you want it as a mixed drink?
Yeah, exactly. Precisely.
So I guess rounding about all the different ways you can treat hyperkalemia.
Absolutely. So number one, we have the Kayexelate, which honestly is probably the most common.
Yoo-hoo! Yeah.
The most common type of hyperkalemia treatment. But like you said, it is kind of delayed. It has a delayed effect. So you have to wait for that patient to have a bowel movement. And, they complain that, once they have a bowel movement, they honestly keep going for a couple more bowel movements.
Yeah.
So you have Kayexelate, you have IV insulin followed by D50.
Mm-hmm.
We have beta adrenergic drugs, which are your nebulizer treatments.
Albuterol. Mm-hmm.
We
Most
have
common.
sodium bicarb.
Mm-hmm.
And lastly, we have to
Calcium.
look out for
Arrhythmias, yeah. And then you can
Arrhythmias.
give calcium in the meantime while you're treating. And then, of course, hypokalemia, you just really got to figure out the problem. I had a patient the other day who came in with severe diarrhea. His electrolytes were all over the place. And we just couldn't keep up with him. Yeah. Poor guy had bowel movements like 10 times a day. How do you keep up with that?
Right. That's tough.
And you can't give him too much because it's like, what if his diarrhea all of a sudden stops? Then you're like, oh, crap.
Yeah.
So, just take it easy. I mean, I know calcium levels are important. But as long as you get near normal, you're usually pretty good. You can't be doing things that are like completely way off kilter. You can't have a potassium in the 7s or
That's
even,
wild.
the 6s. That's a lot.
Yeah, that is.
Or you can't have a potassium in the 2s. If you're like 3.4, 3.3, 3.5, you're usually probably okay. But more importantly is keep an eye on those arrhythmias. Keep an eye on their symptoms, muscle soreness, arrhythmia, heart palpitation, stuff like that.
chest pain, that sort
Pain,
of things.
yeah.
Yeah.
So, those are all contributing factors, and it's important, I guess, as nurses, because potassium is such an important electrolyte, and it's an electrolyte that is more off balance, I feel, than most others, at least in my practice, the population I work with. It's always potassium. And, if you get behind in treating it, you can be in some real trouble.
Absolutely.
So keep an eye on it, yeah. But yeah, that's it for that.
We really hope you guys learned something from this episode. It is, again, our season finale.
Yeah, we're done. We'll be back next year, though. It's not that much longer. It's only like a few weeks. But
yeah. So again, we appreciate you guys so much for following along with us this season. We hope that we gave you guys some awesome information, that you guys learned a lot from what we had to say and our stories within our practices, of course. We wish you all the best of health throughout the holidays. Stay safe through this holiday season. We wish you guys a happy new year.
Happy New Year. Don't have parties, man. Let all this COVID stuff die out. I mean, you can do what you want. I'm not going to tell you to live your life, but shit. I'm so tired of it. I don't want to do this anymore.
I know. I feel like
COVID
the exhaustion is real within the healthcare society. But thank you again. Please like, subscribe, follow us on YouTube, on Instagram at The Realist Nurses, Spotify, Google Podcast, Apple Podcasts. Where else are we? That's it. That's pretty much it.
Instagram, yeah.
All right, guys, that's a wrap. Happy New Year. Happy holidays.
Yeah. And if you're a graduate nurse and you're looking for a job, we have some really cool stuff coming up. We're starting to look at resumes, and I've already looked at a few myself. They're pretty good, but we've got a lot of tips coming up, but we're throwing out free resume reviews. Instead of podcasting, we'll be spending our time doing that. So there's going to be more information in our profile, especially on Instagram. You can look at how we're going to, throw that out there, and how you can sign up to get your resume reviewed before your interviews. I know a lot of people are doing things with the turn of the new year, so if that's something you're interested in, holler back.
Bye.
See you.
The Shift Report.